leveling it into arch would have a very bad prognosis. But afterwards, this is the sequence, and you can see it's a very long sequence, and you can see that the bite is kept quite down. How this is done? In a patient that has got a tendency for vertical growth, and you want to try to keep the bite down, but you don't need very complicated tools like bite blocks or extra or free anchorage, you can do this just by leveling very slow. Personally, I use 3 months at 0.12 night high, 3 months at 0.14 initial LOI, 3 months at 0.18 initial LOI before proceeding to rectangular arch wires like bioactive. You also want to avoid in this patient to go in full-size steel wires, because any kind of lack of precision in placement of bands, tubes or brackets, you risk to pay that very hard, because in a patient that is posterior grower, if you go in full-size steel and you get pre-contacts, the bite open up and can get very difficult to control. So whereas normally I finish my patient in 1925, 2025 steel, in this patient sometimes I go only up to a full-size rectangular wire, bioactive, for example, or shifting steel in one arch, having bioactive in the other arch. So no full-size steel in both arches at the same time. Of course, there is also same procedure as the other patient, some repositioning that allow to close the bite further and to come to a final result. Interesting to see that the look stays the same. But what is interesting to see is the profile, that despite vertical growth, the profile, I would say, improved during growth. And you can see that there is a very nice curl. Of course, there is also an aspect that is natural growth that occurred that it was not unfavorable, but all we can say is that we have to try to not worsen what nature offers us. These are the superimposition, and this is the final occlusal result. Of course, there are only 3 incisors, therefore the midline is centered on the lower central incisors, but there is otherwise an acceptable level of occlusion. This is, again, compared with the articulator mounting, so that there is also, you can see that there is no discrepancy between centric relation and centric occlusion. This was about controlling the lower molars. What about the upper molars? Which are the most common problems that we have there? The most common problem by far is that we can have hanging palatal cusp of the upper second molar. Why do we have this? We have this is due to the way that upper second molar erupt, and this is due also to the fact that very often they are the expression of dental-alveolar compensation to a transversal discrepancy. So basically, whenever you have a maxilla that is constricted with respect to the lower arch, the upper molars will tend to flare out to try to compensate this. Being flared out will give hanging palatal cusps. How can we address this problem? A first way is to use, of course, transpalatal arches. And for this one, we use the example of Elizabeth. Elizabeth, she's a girl. She comes to my practice, and she doesn't have major issue from an extraoral point of view. And intraorally, also, she doesn't have so big problems. She's got some lack of space, some flaring, but you can see she's got a rather neutral occlusion, no big problems. So this is an easy case. We just have to control that there is space enough for all teeth, and you can see and look at the amount of overbite. Right now, she's got a rather deep bite. This is a case in which we are not doing much. We are just placing brackets, wires, and waiting. But what happens then? It happens then, all of a sudden, our bite starts to get more and more open. We get it here. We start to have a total lack of intercuspidation on the posterior aspects. We get it here. can you see that now the two arches basically are not touching anymore? Why? Because if you look at the second molars, they are very much flared out. How can you see this? Well, you have to take, again, as I said before, intermediate impression. If you look at it in the mouth, it's very difficult to notice. Once that you see this, how can you correct this? As I said before, one way is to use transpalatal arches, activated for torque and for the slight contraction of the second molar, with which we are trying to intrude the palatal cusps, so to close the bite. And this has got a very good effect because you can see immediately the bite closed down. If you go back, you notice before inserting there was a lot of space between the upper and the lower arch, and just after it tends to close down. You have to keep doing this for several months. It takes long. But then you can get to a point in which you get an acceptable occlusion, and then you can finish your case with an acceptable extraoral result. I didn't change the gender of my patient during treatment. I cannot do that with treatment, with fixed appliance. The extraoral appearance stayed rather the same. She had normal growth. What is important to see is that it was possible to achieve a very good intercuspidation at the end of treatment by taking care of posterior precontacts. Sometimes we cannot just do it, because sometimes our problem can be the morphology of the second molar. What happens if we have an extreme malformation of the second molars in the upper? What happens if we have a malposition that is so marked that we cannot correct it? Well, in that case, you have two ways to do. You can make coronoplasty, or if you want to be more honest, you can say you have to take a burr and try to slide a little bit the tooth, or you have to extract some time. You have to extract the second molar. This is Louise. Louise, she was one of my terror patients because she's a girl, 16, good looking, from a good family, extremely spoiled. So she has got all the points that make of her a bad girlfriend and a bad patient. For me, it was a bad patient. So this is her appearance. You can start to see, by looking at the extraoral picture, that she's got a certain degree of maxillary hypoplasia. When you look at her, you can see she's got some flatness of the paranasal area. She's got a rather flat upper lip, flat lower lip. She's a class 3 open bite patient. You can also see that looking at her X-rays, and you can see it even more looking at her intraoral picture. This is the way she bites. I apologize a little bit for the quality of the picture, but this is a very old case. So at that time, this is what I got from my photographic skills, that they didn't prove much in the MIWAL, but you can see the patient has got open bite. Occlusally, she's more or less neutral, but that is typical of class 3. When a class 3 is also open, the fact that the mandible is posteriorly rotated will give you a neutral occlusion, even if though it's a class 3 skeletal. There is posterior crossbite because the maxilla is deficient, and very severe crowding, both upper and lower arch. So, such a patient for me is best served with a combined treatment with orthodontics and surgery. However, I treated this patient in Denmark. In Denmark, I cannot decide if the patient will get surgery. It's a committee of surgeons that has got to decide if the patient has got the right to get a free operation. So I send the patient to this committee. This committee say, well, maybe, but we would like you to try first without. And I said, thank you very much, that is beautiful, but I will have to do it because that's the way. A patient in Denmark, normally they cannot pay a private operation. There is no place in Denmark where private operations are done with relation to jaw surgery. So the most obvious solution here was start with extraction treatment, because of course a patient has got already this kind of open bite, class 3, you cannot avoid extractions here. So I extracted 4 premolars and I started to treat the patient. I started to close the space, but this is the kind of bite opening that I had. There is no hope to put these 2 arches together. Why was the situation? Well, if you look at that, the situation was due to the fact that, look at the second molars, they are over-erupted probably around 5 or 6 millimeters. Now, how can I control this? Many of you start to think mini screws. Unfortunately, there was a little contraindication. This case is before mini screws existed. So I couldn't use something that didn't exist, surprisingly enough. Then you can tell me, you can try with a transpalatal arch placed very low. You could do it, but this is a bit too much for that, and especially the patient wouldn't tolerate it in any way, because as I told you, she was not really the most cooperative that I ever had. Since the patient had the 3rd molars, I decided to extract the 2nd molars. And I know I had already extracted 4 premolars. So she had extracted 4 premolars and 2 upper molars. So, after extraction, you can see here there is space. What was done was to include into the arch in the upper the 3rd molar as soon as they erupted. What happens when you do this? Well, of course, the 3rd molars will erupt very quick, but you will also get a little bit of intrusion of the posterior part of the upper arch. Basically, you will simulate in this way a Lefort 1 osteotomy with posterior impaction, which is what is used to close the bite surgically, or was used. And you can see by doing this, I start to achieve what looks like a more decent intercuspidation. These are the 3rd molars, the 2nd molars have been extracted, and the 3rd molars have been coming down in place. I referred her for extraction of this 3rd molar, and the surgeons told me, no, we don't think it should be extracted. So my relationship with surgeons in Denmark has not been very idyllic, in this case at least. This is the final result. Of course, it's not perfect. It's a compromise. However, considering the situation at the start, that was this one, all in all, I think is an acceptable result without surgery. But what about extraorally? Extraorally, this is the change for the patient. This is before and after. And what is interesting to see is, what about her profile? Do you think got worse by extracting 6 teeth? Well, this is before and this is after. She's of course still a class 3 patient. There is no doubt. But still, if you look at this and this, can you see the lower lip, for example? This one is very straight. Here, there is a bit more of a curl.